Welcome to the medical nursing unit. Topic 3: disorders of digestive system. Disorders of alimentary tract. The first disorder we are going to see is gastritis. The gastritis, it is a common disease. Many people, they suffer from gastritis. Gastritis is designed as an inflammation of the gastric mucosa. It can be classified as acute gastritis or erosive, or chronic gastritis non-erosive. This is an inflammation of the gastric mucosa. Let's see acute gastritis. Acute gastritis has a number of causes, including certain drugs, alcohol, bile, ischemia, bacteria, viral and fungal infection, acute stress, radiation, allergy, and food poisoning, and direct trauma. Those can be the cause of acute gastritis. The common mechanism of injury is an imbalance between the aggressive and the defensive factors that maintain the integrity of the gastric lining. Our gastric lining or mucosa are protected from the gastric juice. Now, when there is imbalance between in defense, the gastric will be injured. We want to see how it happened. The gastric mucosa exhibits hemorrhage, erosion, and urethra. Non-steroidal anti-inflammatory drugs such as aspirin, ibuprofen, and naproxen are the most common agent associated with acute erosive gastritis. Those anti-inflammatory, non-steroidal anti-inflammatory drugs such as aspirin, ibuprofen. Most of the time you used to take those drugs, especially ibuprofen, for anyone who suffers from any easy headache, any back pain. You used to take ibuprofen, but please you have to pay attention because ibuprofen or aspirin can cause erosive gastritis. These result from both oral and systemic administration of these agents, either in the therapeutic dose or in the supratherapeutic dose. Sometimes they think that when you use systemic ways to administer such drugs, they don't expose the gastric. No, it is not, because the mechanism of acting is the same. Yeah. You pay attention taking ibuprofen, this can be associated with the gastritis, and it is not good to give a patient those drugs, aspirin, ibuprofen, naproxen, and others who suffer from gastritis. While we are receiving the client and we are thinking that she may have or he may have gastritis, before prescribing those drugs, you have to ask if he doesn't have any problem of gastritis. Because of gravity, the inciting agent lies on the greater curvature of the stomach when we take such drugs orally, and this part explains the development of acute gastritis distally on or near the greater curvature on the stomach in the case of orally administered. For the client who suffers from even gastritis, it is understandable. After 2 hours of taking the ibuprofen or other drugs or aspirin, they will suffer from a gastric pain. Here, those drugs they lie on the greater curvature of the stomach, and they can cause erosion there. But the major mechanism of injury is the reduction in the prostaglandin synthesis. Normally, the prostaglandins are chemicals responsible for maintaining mechanisms that result in the protection of the mucosa from the injurious effect of gastric acid. Our stomach, our mucosa of our stomach are protected by prostaglandin. Are protected by prostaglandin. from the gastric acid. If there is imbalance in this mechanism, maybe if we stop prostaglandin, the gastric acid will injury our mucosa. And we know those non-steroidal anti-inflammatory drugs, most of the time they block prostaglandin actions. If they block prostaglandin actions, it means that we will miss the prostaglandin to protect our stomach. So the gastric acid will injure our stomach, our mucosa of our stomach. This is, however, the principal mechanism of how those drugs can affect our gastric mucosa. Bacterial infections is another cause of acute gastritis. Helicobacter pylori is the most common cause of gastritis. Helicobacter pylori, H. pylori gastritis typically starts as an acute gastritis in the antrum, causing intense inflammation, and over time it may extend to involve the entire gastric mucosa, resulting in chronic gastritis. Most chronic gastritis is related to Helicobacter pylori. Etiology of acute gastritis. The first, these microbes, Helicobacter pylori, is the first cause. Other bacteria, we can see Staphylococcus, Streptococcus, Escherichia coli, herpes simplex virus, cytomegalovirus, inacquired immunodeficiency syndrome, stress-induced acute gastritis, especially for the critical ill patients. Even the stress can cause gastritis. Yeah. How to avoid the stress? That is why we will see for those people who are critically ill because they think they may have a stress, they administer anti-proton pump like omeprazole. When you have a stress, the acid is produced so that they can injure the client. So H ions they produce in many quantity, and they can induce the gastric acid. So to avoid that, they administer such drugs, those anti-proton pump. You will see for everybody who is critically ill, for those who are a severe fracture, for those who are in ICUs, they most of the time administer omeprazole. Where we will see them, even if the client will not have a gastritis, but that will be in protective, is in preventive measures. You will see why you will be in clinical. What are the clinical manifestations of acute gastritis? We have epigastric discomfort, anorexia, bloating, cramping, nausea and vomiting, sometimes gastric hemorrhage, heartburn. The symptoms last only a few hours or days. The heartburn, this is ikirungurira. Bloating, this is kubyimba kwinda. A diagnosis. We use endoscopy or gastroscopy, laboratory examination of gastric secretion, identifying H. pylori. Endoscopy. This is a process that they do to visualize the inflammation in the gastritis. They pass through the mouth until the stomach. Treatment, we have antacid, hydroxide of aluminum, gastric mucosa protector, Malox, stress coping strategies, avoid the causative factors like alcohol, pepper, and caffeine. Yeah, those stimulants like alcohol, pepper, and caffeine, they stimulate the gastric juice. Let's summarize the pathophysiology. The progressive inflammation of gastric mucosa causes progressive atrophy from the superficial lining to the deeper part, destroying the mucosa gland, decreasing the function of intrinsic factors that impair absorption of vitamin B12. The destruction of small vessels may cause hemorrhage, and chronic inflammation may expose to ulcers. I think it is understandable here. Causes on the risk factors: autoimmune cause, Helicobacter pylori, alcohol ingestion, tobacco, paper, radiation therapy. Clinical management, clinical manifestations: we have anorexia, nausea, vomiting, abdominal discomfort, episodic epigastric pain relieved by ingestion of food, hematemesis, pernicious anemia. Hematemesis, this is the presence of the blood in the stool. And pernicious anemia, this is the anemia related to insufficient absorption of vitamin B12. Diagnosis: the same as acute gastritis. So, hemogram and the okay. Diet therapy: avoid alcohol, tobacco, and food, spicy food. You tell the client to avoid alcohol. For those clients with gastritis, they are not allowed to take alcohol, tobacco, fatty food also, and the spicy food. Spicy food, those are the food with birungo. Antibiotic in the case of H. pylori cause antacid, fluid replacement accordingly. Vitamin B12 in the case of pernicious anemia. Peptic ulcer disease. When we say the peptic ulcer, we understand the mucosal erosion equal or greater than 0.5 centimeter of an area of gastrointestinal tract that is usually acidic and thus extremely painful. It will be called peptic ulcer disease, where the client will develop a ulcer on the mucosa. Types: we have a gastric ulcer and a duodenal ulcer and a mixed ulcer. A patient can only have a gastric ulcer or duodenal ulcer. Okay. How is it now? This bacteria, Helicobacter pylori, and smoking are responsible for hypersecretion of hydrochloric acid by stimulating gastrin production. Smoking and these bacteria, they cause the hypersecretion of hydrochloric acid by stimulating gastrin production. The decreased mucosal synthesis of prostaglandins by liberation of histamine, or the use of irrogenic drugs such as non-steroidal anti-inflammatory drug, is also responsible for acid secretion. The hypersecretion of gastric acid causes gastric and duodenal erosion called ulcers. Normally, when we say duodenal ulcer and gastric ulcers, we understand that there is the hypersecretion of the acid, but we have a cause. For any cause that can cause hypersecretion of gastric acid, the gastric acid will erode, will burn the. I think it's like to burn the mucosa, and we will see their wound. And those factors that cause hypersecretion of gastric acid, we include those bacteria, Helicobacter pylori, and smoking, and those drugs, non-steroidal anti-inflammatory drugs. Now, even chemotherapy can cause it, radiation therapy, and Crohn's disease. Okay. Those are the causes. Risk factors, of course, those people who smoke, they are exposed to develop the ulcers. Advanced age also. Habitual use of non-steroidal anti-inflammatory drugs. Those are people who take as they want, the ibuprofen, whatever, they are exposed to. Alcoholism, those are people who drink much more alcohol. Now, chronic disease, stress-induced, infection of the gastric and duodenal mucosa with Helicobacter pylori. They are at risk to develop ulcers. In the gastric ulcer, let's see the clinical manifestations. In the gastric ulcer, the epigastric pain described as burning is caused by ingestion of food pain pattern, and relieved by antacid pain, antacid relief pattern. This can be characterized by ulcer. If the client suffer from epigastric pain, described as burning, and caused by injection of the food, while they ingest the food, they feel pain, and while they take antacid, they relieve pain relief. Then now we can characterize as ulcer. The pain occurs immediately after eating and tend to be chronic rather than alternating between period of remission and exacerbations. How will we differentiate a gastric ulcer and a duodenal ulcer? In the duodenal ulcer, there is a chronic intermittent pain in epigastric area. The pain begins 2 to 3 hours after eating, when the stomach is empty, and is relieved by ingestion of food relief. So here the client will suffer from pain. When the client is suffering from epigastric pain, how to diagnose if it is gastric ulcer or duodenal ulcer? For gastric ulcer, we have said now, when he take a food, he immediately feel pain. Immediately, when he ingesting, it will characterize gastric ulcer. But if the client expresses that he develops the pain after 2 to 3 hours, now we can think about duodenal ulcers. The pain may occur at night for both. The burning pain usually lasts between 30 minutes and 3 hours. Hematemesis and the merena. Hematemesis, this is vomiting the blood, and the merena, anorexia, nausea, vomiting, weight loss, especially in gastric ulcer, bloating, heartburn, pernicious anemia may be present in the case of gastric ulcer. Complications: you can have hemorrhage, gastrointestinal bleeding, gastric or duodenal perforation, peritonitis or pancreatitis, gastric cancer in the case of gastric ulcer, duodenal narrowing or obstruction. Diagnosis: epigastric burning pain. We can use the endoscopy, and we see esophageal duodenoscopy can be used, barium contrast X-ray, biopsy, culture of circulation to confirm Helicobacter pylori. Differential diagnosis: we can confuse gastritis, stomach cancer, gastroesophageal reflux, pancreatitis, cholecystitis, biliary colic, referral pain, Zollinger-Ellison syndrome. Those are the differential diagnoses that we can confuse with the peptic ulcer. What is the management? Give antacid, hydroxydominum, H2 antagonist, this is cimetidine, ranitidine, and the misoprostol, Ostotec. It is a prostaglandin analog. When the patient is taking non-steroidal anti-inflammatory drugs, it is Ostotec on misoprostol. It is used to induce the labor for the women, but because it is a prostaglandin analog, they stimulate the production of the prostaglandin, and they add the prostaglandin. I know the prostaglandin can protect our mucosa, so we administer to those patients and we increase the protection of the mucosa. When Helicobacter pylori infection is present, association of 2 antibiotics and 1 protopump inhibitor, what we call tritherapy, is used. The tritherapy is composed of 2 antibiotics and one proton pump inhibitors. Example, we can give amoxicillin or clarithromycin plus metronidazole plus omeprazole. We have two antibiotics, amoxicillin and metronidazole, or clarithromycin and metronidazole, and plus plus proton pump inhibitor, known as this is the therapy. Diet therapy also, we can take fresh milk, avoid food containing spicy, acid, or fat. Now, those people who are suffering epigastric pain, I advise them to take a fresh milk in chushu, and avoid containing spicy food and fat. Avoid smoking, alcohol, and other irritants such as coffee. Take food regularly. For those clients who suffer from epigastric pain, now I advise them to take food regularly. When I say regularly, if it is at noon, at 12, is at 12, not to take at 7, no, it is not. And stress coping strategies now, because the stress and the use H2 production, now we have to reduce the stress cop and with the overall stress coping strategies like relaxation, sport, physical exercises, dancing, music. So it is very important. Now you are reducing stress. Okay, you can change your activities you are doing. Now you can take time and go to relax. Yeah, you have to develop your strategies, stress management strategies. And the surgery can be used, the gastrectomy and vasogotomy can be performed. What is Zollinger-Ellison syndromes? This is a rare disorder caused by tumor in the pancreas or in the duodenum. This is causing urethra in the stomach and the duodenum. Zollinger-Ellison syndrome is common in people between 30 to 50 years old, and men are more affected than women. And me too, I have never seen this pathology. Hiatal hernia, I think these have been studied in a surgical one. Yeah. This is a hernia. This is herniation of upper part of the stomach into the thoracic cavity through the esophageal hiatus in the diaphragm. And the hernia you have seen is surgical, that is the deplacement of a portion of the one organs into another organs, of course. Now, this is for this hiatal hernia, this is the herniation. When it's a herniation of upper deplacement now of upper part of the stomach into the thoracic cavity. You can see how the gastric chemical, you can see how the position of the stomach have depressed through to the esophagus. Now you can see this is a normal stomach, and you can see here how the stomach depressed now over in the thoracic. Okay, here in the esophagus. This is the hernia. Okay, those are types of hiatus hernia. You have understood in the surgical one, in the surgical unit. Okay, let's continue. Okay, let's see malabsorption syndrome. The malabsorption syndrome is an alteration in the ability of the intestine to absorb nutrients adequately into the bloodstream. We know very well that if we eat the food, we share it by the teeth and we swallow it, arriving the stomach. The stomach we mix with the juice, where there will be ingestion, the chemical ingestion, and after that we remove the ingested food will remove into the small intestines where the absorption will happen. When we say malabsorption, it is happening in intestines now, and we know those small nutrients are only allowed to pass through the small intestines into the blood. So when this we have the problem on the intestines that can impede to pass those nutrients, we will have malabsorption syndrome. It may refer to malabsorption of one specific nutrient or specific carbohydrate, fat, or trace elements. It doesn't mean that if we say malabsorption, it is for all nutrients. No, we can have a malabsorption for one nutrient. Maybe the fat are not absorbed. Maybe the carbohydrate are not absorbed. It will depend. It will depend of the conditions. Now, it may be caused by lack of enzyme due to pancreatic insufficiency, or by mucosal disruption due to gastric or intestinal secretion or intestinal disease, malabsorption. Yeah, I think you understand. Yeah, if we miss the specific enzymes to ingest the proteins, now we have a malabsorption of proteins. Causes. The main cause is the pancreatic insufficiency, because in the pancreas, this is the pancreas that secretes the enzymes now to help us in ingestions. When you have a insufficient pancreatic secrete production for those enzymes such as lipase, amylase, trypsin, chymotrypsin that are required for digestion of proteins, carbohydrates, and fat, we will have a problem of digestion and also problem of malabsorption. A genetic defect also can be, and bile salt deficiency cause fat malabsorption. We know the bile salt helps us in the digestion of the fat. Yeah, if the bile salt is insufficient, the fat will not be absorbed, and the poor fat soluble vitamins, okay, cannot be absorbed. Radiation therapy may induce the mucosal lining of the intestines. Okay, may injure the mucosal lining of the intestines. Now, if the mucosa of the intestine is injured, now you can see the absorption will not be happening very well. Now, the clinical manifestations, we have steatorrhea. Steatorrhea. If you have steatorrhea, this is excessive fat in the stool. In the case of pancreatic insufficiency for repast, deficient in the bile salt, also you will say steatorrhea, we understand. We will see excessive fat in the stool. Now it will show us that the repast, those enzymes necessary for fat digestion are insufficient. Diarrhea due to mucosal disruption and inability to absorb fluids. Okay, with many other. If the client is having many diarrhea, we sometimes for those people with the immunocompromised HIV in advanced stage, we see you can even administer the porridge. In 2 seconds now the porridge is out from anus. So that when the mucosa is having distributed now, it can't. Anemia in case of inadequate absorption of the vitamin B12, iron, or folic acid. Fat soluble vitamins deficiency with the symptoms accordingly. Flatulence, bloating, diarrhea, cramp pain are the manifestation of fructose deficiency. The treatment, we will have fluid replacement, relieve other symptoms, treat the cause accordingly, adjust the diet according to the cause, administer enzyme parenterally in case of lack of enzyme. Yeah. What is diarrhea? Diarrhea is the loss of water stools for more than 3 times a day and more than 5 times a day for the neonates and small infants. So we will say the client is having a diarrhea. The diarrhea is a common signs the people report at the hospitals, but you have to see if diarrhea. Diarrhea must be the water stool, and we will call diarrhea when the stool is more than 3 times a day for adult and more than 5 times a day for neonates. Acute diarrhea is a common problem that usually lasts 1 to 2 days. It can be prolonged and persist for more than 2 days and pose the risk for dehydration. For the client who is having diarrhea, is having loss of fluid, of course, loss of fluid. So the loss of fluid now can cause dehydration. Chronic diarrhea may be a feature of a chronic disease. Causes of diarrhea. Acute diarrhea may be caused by bacterial infections, viral infections, food intolerance, parasites, reaction to medicine, intestinal disease, and functional bowel disorders. This may be the cause of acute diarrhea. You will read and you will understand. The chronic diarrhea that persists longer than 4 weeks, is considered to be chronic. If the diarrhea persists longer than 4 weeks, they will be considered to be chronic. The causes will be inflammatory causes. Maybe you can have any idiopathic inflammatory bowel disease like Crohn's and chronic ulcerative colitis, lymphocytic and collagenous colitis. Now this is idiopathic. This is with unknown cause. Immune-related mucosal disease. Infections, radiation injury, gastrointestinal malignancy also. Okay, this motile cause, irritable bowel syndrome, and visceral neuromyopathy also can be cause of diarrhea. This motile causes irritable bowel syndrome include post-infection irritable bowel syndrome, visceral neuromyopathy, hyperthyroidism drugs, post-vagotomy also can cause diarrhea. We have seen steatorrhea causes. Now, steatorrhea, this is we say it with the presence of fat in stool. Can be caused by intraluminal maldigestion. We understand. Mucosal malabsorption also. Post-mucosal obstruction can also cause the steatorrhea. Iatrogenic causes, this is for iatrogenic, this is the cause related to the medical procedures. Now we have the cholecystectomy can cause steatorrhea, ileoresection, vagotomy, fundoplications. The signs of symptoms of steatorrhea: frequent elimination of liquid stool, water, and blood, accompanied by clamping, abdominal pain, nausea, fever in the case of bacterial causes. Diagnosis: stool culture, stool direct examination, blood test, sphygmodoscopy, colonoscopy. The complication in this dehydration is the principal complication of diarrhea. Malnutrition is in the case of chronic diarrhea. It is malnutrition, of course. If diarrhea causes malabsorptions and we can have malnutrition. Regurgital products in the case of repetitive diarrhea or chronic diarrhea. Intestinal obstruction due to intestinal invagination can be also happen. The management for diarrhea prevent dehydration by giving ORS or rehydrating solutions. Yeah. When the guy is having diarrhea, you have to think about the dehydration, and you want to manage, and how management is emphasized to the preventing the dehydration or treating dehydration. Teach patient on hygiene, treat etiology, treat dehydration, give the fluid replacement. The fluid replacement may be Rengrag, that is the first choice for those people who have the diarrhea. For our activity as nurses, we monitor vital signs. We assess the signs and the symptoms of dehydration. Those are the dry mouth, mucosal membrane, reduced skin tego, hypertension, oliguria, sucking eye, and etc. and others. Those are the signs of dehydration: dry mouth, mucous membrane, reduced skin tego, hypertension, oliguria, sucking eye. Encourage the client to drink ORS and explain the importance of the solution compared to water. The ORS, oral rehydration solution. Oral rehydration solution. Now, this is ORS. Diving Bahabana, Bagwe area, Navan Bakuba, Ibahari. And you have to explain that they don't like it. Many people, or most of the time, other people, they don't like it. And you have to explain them that ORS contain those elements to replace the lost one. Administer ORS in via nasogastric tube when the area is associated with vomiting. Educate the client about hygiene. Administer prescribed medication, IV line, and administer fluid in case of severe dehydration. Monitor the degree of dehydration and manage accordingly. Monitor and record the frequency and the characteristics of stool. Reassume the client and the family. Let's understand what is the constipation. The constipation is known as difficulty in evacuation of feces that may be accompanied by the inability to defecate. This you understand it. The common cause may be irregular bowel habits, ignoring the need to defecate. When you say ignoring the need to defecate, it can cause a constipation. Is it the time that you can feel you want to defecate now, and you continue, you take the taxi, you go while living in Kigali, you can see the ticket also to Ruhengeri. You go in Ruhengeri, you go and deliver to Ruhengeri. Immediately you say, I will do it at Ruhengeri, I will do it at Giseng. Ignoring the need to defecate now can cause constipation. Please pay attention. Go to the toilet whenever you feel you want. You need. Chronic illnesses, low fiber diet and high animal fat intake. The high fiber diet increase the bowel motility, and the bowel motility will increase eliminations. Now, the low fiber diet will cause the constipation. The diet contain the fiber. We include those oranges, the papaya, and the vegetables. Lack of fluid intake, stress also can induce the constipation. Lack of physical exercises, colon cancer, people depending on heavy laxative drugs or age. Sometimes we don't consider as the lack of exercises as a cause of constipation. This is a problem for the patient or for long hospitalization. They pass long time in the bed and they don't move. If they don't move, the bowel movement is reduced. When the bowel movement is reduced, also the content will remain a long time in the large intestines, where the absorption will occur of the water. So that will be very hard and difficult to defecate. We have to motivate now to encourage people to do some exercises while they are in the bed. The sinus symptoms, we have abdominal pain, bloating, staining during defecation, staining during defecation, no stool for 3 consecutive days, or solid stool of inadequate volume. Yeah, this is the client will complain a no stool or for 3 consecutive days. That will define as constipation, but also can be solid stool and inadequate volume. Now, defecation, it becomes as constipation. The complication can be hemorrhoids, rectal prolapse because of staining, staining and intestinal obstruction for fecal impaction, and hernia can occur. Diagnosis: a functional constipation is a clinical diagnosis that can generally be made on the basis of typical history and an essentially normal physical examination, including one of the rectal examination, is a key part of the initial evaluation. Treatment: diet therapy, encourage fiber, fruit intake, green vegetables, fruit like papaya, fruit intake. The water or sea, taking the water or sea will reduce. Taking the water or sea is important in preventing constipation. You can have and we advise physical exercises, as we have said, We can do enema cleansing may be required. Enema, this is to help the people for elimination. Now, laxative, I think enema you have studied in the first year. Laxative also, this is drug oral polyethylene glycol is better tolerated. Irritable bowel syndrome. This is a functional intestinal disorder characterized by abdominal pain, bloating, and irritation in the bowel habit with no specific or unique organic pathology. You will see many people, they consult the hospital complaining the abdominal pain and the bloating, and when with echography, they know organs is having a problem. Sometimes you will think about irritable bowel syndrome. Okay, the predisposing factor can be infections. Now, the symptoms is abdominal pain, abdominal bloating, belching or flatulence. The flatulence are the bowel habits, either diarrhea or constipation. Patients sometimes complain of dyspepsia, heartburn, nausea, and vomiting. Okay. Diagnostic criteria for irritable bowel syndrome. Recurrent abdominal pain or discomfort at least 3 days per month in the last 3 months, associated with 2 or more of the following sinus symptoms. If the client will have abdominal pain or discomfort at least 3 days per month in the last 3 months, associated with 2 the following symptoms: improvement with defecation. If they feel pain, but when they go to the toilet, the pain relieves. Onset associated with a change in frequency of stool. Onset associated with a change in form of stool. Treatment: dietary modification. Avoid some food that may aggravate symptoms: coffee, disaccharide, legumes, and cabbage. Fiber supplements and antispasmodic drugs, anti-diarrhea drugs, psychotherapy, antidepressant therapy also can be given. Let's see disorders of the liver and the biliary tract. The common pathology we see is cirrhosis. When we say cirrhosis, is irreversible inflammation and fibrosis of the liver due to various diseases that kill the liver cells. When we say cirrhosis, we understand now the affection of the liver. Many causes are there. The principal cause of cirrhosis is alcohol. You understand cirrhosis, alcohol cirrhosis. Chronic viral hepatitis like hepatitis B, hepatitis C, hepatitis D, and autoimmune liver disease. Autoimmune. When we say the autoimmune disease now, when we say autoimmune, we understand the destruction of some cells of tissues by our antibodies. It happens when you have a repetitive inflammation. You know, when you have an inflammation now, we really create infection of the inflammation. The antibodies are recreated. When antibodies are there, yeah, maybe for some time they will kill even the cells. They really fail to know itself, the body and the bacteria and the other, and they will kill the cells and they cause autoimmune disease. Medications: no alcoholic fatty liver disease, cholelithiasis, cystic fibrosis. That can be the cause. The sinus symptoms of cirrhosis: frequent attach of indigestion with nausea, vomiting, and diarrhea. The nausea, vomiting, and diarrhea, anorexia, abdominal pain, especially in hypochondriac region, right? Yeah. Low grade fever, full breath, loss of weight, jaundice. The jaundice is the typical signs of a liver affection. The jaundice, this is the yellow color, like a blue, the yellow color of the bulbar conjunctiva of the eyes. The standard veins in the abdomen also can be a sign of symptoms of cirrhosis. The liver and spleen may be enlarged, what you call hepatosplenomegaly. Complications. The complication of cirrhosis is portal hypertension. The portal hypertension, this is the hypertension in the portal vein. We know what is the portal vein. This is the vein that collects the nutrients absorbed. Now, you know, on small intestines, when we eat now, the nutrients, when the foods, ingested food arrive in the small intestine, we have seen that there is reliable solution. Those reliable solutions, those small nutrients, they go into the small vessels, capillaries around the intestines, and those all capillaries around the intestines, they carry the content into the portal vein. The portal vein carry all content from the intestinal to the liver. And this is when there is hypertension, when the liver cells have been injured, now they will not work as normal, and those from the portal vein, in the portal vein, will accumulated and will create a portal hypertension. Gastroesophageal varices, gastroesophageal varices is a complication. The varices, this is swelling of veins. Portal hypertensive gastropathy, splenomegaly, hypersplenism. Aside is accumulation of the fluid in the peritoneal cavity. Spontaneous bacterial peritonitis. Hepatorenal syndrome. This is the complications of cirrhosis. Okay, we can also have hepatic encephalopathy. Hepatic encephalopathy, portopulmonary hypertension, and malnutrition as a complication. Coagulopathy, deficiency factors of coagulation factors deficiency because are produced by the liver. Fibrinolysis, thrombocytopenia because the liver is responsible to produce the platelets. Bone disease, osteopenia, osteoporosis, osteomalacia. Hemorrhagic abnormalities, anemia, hemolysis, thrombocytopenia, and neutropenia. This is the complications. Diagnosis: the bilirubin is elevated. The bilirubin elevated. Now, when I say the bilirubin, do you understand the bilirubin? Bilirubin, you know how the bilirubin is produced. Now, the bilirubin is produced by the when you say is elevated in the blood, this is unconjugated bilirubin. Okay, we know the bilirubin most of the time is from the destruction of the red blood cells. We know every day you have the destruction of the red blood cells, and this is the hem of the red blood cells, bilirubin, and the bilirubin should be eliminated because it is toxic. Now it should be eliminated. How a bilirubin should be eliminated? The bilirubin, when it's alive in the liver, they have to be conjugated to the cholesterol and the produce the bile, and they produce the bile. If the bilirubin if the cells of the liver is not functioning, the bilirubin will not be conjugated. If the free bilirubin will continue to circulate in the blood, that's because the bilirubin is having the color tend to be blue, blue color, yellow color. That's why we see the change of the color of the mucosa, especially of the belly bar or the eyes. Jaundice. The jaundice is the characteristics of the free and conjugated bilirubin in the blood. Yeah, the bilirubin should be conjugated and form the bile and be eliminated through digestive tract, because the bile salt will come to help in ingestion of lipid and be eliminated. Okay, if the liver cells are not functioning very well, you can see this bilirubin will not be conjugated. Yeah, and we have bilirubinemia. Blood liver test, we can say alanine transaminase and the aspartate transaminase. Those are enzymes that characterize the function of the liver. Yeah, you will see in the hospitals the test for at least every patient. X-ray may be used to diagnose it. MRI, ultrasound, and liver biopsy can be taken to study what is happening. The management: treat the cause. Maybe we have to abstain from alcohol. Antiretroviral drug in the case of hepatitis. supportive care, manage the complications, and liver transplant can be happen in those developed countries. Nursing management for cirrhotic patients, educate the patient about diet, alcohol abstinence, fat restrictions, and explain the reasons. The fat restriction will be there because of the lack of the bile salt, of course. Then the bile salt is necessary for digestion for the fat, and the bile salt is formed by the liver cells. Provide supplemental feeding, recommend cessation of smoking, provide hygienic care, administer prescribed medications, assess the signs and symptoms of gastrointestinal bleeding, monitor vital signs, assess and not change the mental status and the level of consciousness for hepatic encephalopathy. IV line to administer fluid, NG tube insertion if indicated, collect lab samples and send to laboratory, collect lab results, assess nutritional status, weigh the client, proteinemia, mid-upper arm circumference for BMI, assess the client's level of pain. Okay, let's see what we have said. Portal hypertension. The portal hypertension is an increase in blood pressure within a system of veins called the portal venous system. The normal pressure is 3 mm of mercury. The portal hypertension is an increase to at least 10 mm of the mercury. The cause is disease prehepatic, portal vein thrombosis, splenic vein thrombosis, massive splenomegaly. We have said here portal vein, I explained it before, and when there is any obstruction, they can cause hypertension in prehepatic. This will be prehepatic cause because that will not be related to the liver cells. And hepatic, this is pre-sinusoidal schistosomiasis, congenital hepatic fibrosis, sinusoidal cirrhosis, alcoholic hepatitis, post-sinusoidal hepatic sinusoidal obstruction. This is hepatic cause of portal hypertension. Post-hepatic now also infection in vena cava webs, Barb-Chiari syndrome, and cardiac cause. The congenital congestive heart failure also can cause the portal hypertension. A pathophysiology of the portal hypertension is due to a disorder that obstructs or impedes blood flow through any component of the portal venous system or vena cava. Yeah, I have explained it before. The thrombosis, inflammation, or fibrosis of the sinusoids as occur in cirrhosis of the liver, viral hepatitis, or schistosomiasis may cause the obstruction of portal vein. The portal outflow to the vena cava can be impeded by hepatic vein thrombosis or cardiac disorders that impair the pumping ability of the right heart. This causes blood to back up and increases pressure in the portal systems. Yeah, it is understandable here. I have said about it. Long-term portal hypertension causes several problems like varices. The varices is distended of the collateral veins in the lower esophagus, stomach, and the rectum. Splenomegaly also is caused by increased pressure in splenic vein, which branches from the portal vein. There is a branch for of the vein that connect the portal vein to the spleen. So if you have any problem of portal hypertension, also you can see this vein will have also hypertension and cause splenomegaly. Ascites is due to increased pressure in mesenteric vein. Hydrostatic pressure forces the water out of these vessels and into peritoneal cavity. Now we can see ascites will occur when during a portal hypertension. Now we see there will be accumulation of the much blood, and the water will shift from the veins to the peritoneal cavity. Yeah. Hepatic encephalopathy is due to presence of the toxic substances, particularly ammonia, in blood that reaches the brain. Of course, now we understand, we know very well the liver purify the toxicity of the food. Now, most of the time, ammonia, this is the product of protein degradation. Now, should be eliminated through ammonium formation. But if the cells are not able to eliminate the ammonia will circulate in the blood and it is toxic to the brain, and this toxic will be called hepatic encephalopathy. Clinical manifestations: gastrointestinal bleeding, anemia, melena, ascites, distended collateral veins, giving rise to the description of captive medusa head, peripheral edema, splenomegaly, hemorrhoids. The individual usually has a history of jaundice, hepatitis, or alcoholism. Diagnosis: clinics and endoscopy, thrombocytopenia, evaluation of portovenous pressure, and management: one GVB blockers, emergency management of bleeding varices, vasopressor, compression of the varices with an inflatable. Okay, liver transplant also may happen. Let's understand what is ascite. The term ascite refers to accumulation of fluid in the peritoneal cavity. Causes: liver disease, cirrhosis, portal hypertension. Cancer: peritoneal cancer, pancreatic cancer, colon cancer, stomach cancer. Obstruct the normal flow and increase the pressure in the vessels. I have said that when the pressure is increasing the vessels, the water will shift from intravascular to extravascular, and they will see where to accumulate. Now, they will accumulate in the peritoneal cavity. Is where we have the volume and the space. Congestive heart failure also can cause the ascite, especially right-sided heart failure, because we have seen heart failure. If you have right-sided heart failure, the blood will back up into the systems now, where the edema will occur, so the pressure in the veins will increase. So, and the water will shift from the intravascular to outside, and you see where to accumulate. They will accumulate in the peritoneal cavity. Renal failure also will cause ascites. Infection, like tuberculosis, bacterial peritonitis, cause increased capillary permeability with loss of plasma and ascite. This is ascite, now accumulation of the fluid in the peritoneal cavity, and it is understandable how the liver disease can cause the ascites, and the heart failure can cause ascites. Mechanism of ascite caused by cirrhosis. The cirrhosis cause a hepatocyte failure or and portal hypertension. When I say hepatocyte, this is the cells of liver. They fail for working. The hepatocyte failure is responsible for decreased albumin synthesis, resulting in diminution of capillary or counting pressure with decreased effective plasma volume. So this is the pathophysiology. When the liver cells failed to work normally, and we know the liver cells synthesize albumin protein. This albumin protein is very important in retaining water in the blood. Albumin, this is a protein that retains the water in the vessels. When the liver cells are not functioning very well, the albumin secretion will decrease. Where will decrease albumin, also uncontrolled pressure will decrease in the capillary. What is the uncontrolled pressure? This is the pressure caused by the proteins in the vessels, and this pressure helps us to maintain the water, and keep the blood volume. Keep the blood volume. If this pressure is reduced, the water will shift from vessels to outside. Okay. Now, understand that the abdomen is principal protein for oncologic pressure. Okay. While we have decreased synthesis of abdomen in the liver. Let's see pathophysiology of portal hypertension. The portal hypertension is due to any disorder that obstructs or impairs the blood flow through any component of the portal venous system or vena cava. I explained it before. The thrombosis, inflammation of or fibrosis of the sinusoids, as occur in cirrhosis of the liver, viral hepatitis, or schistosomiasis, may cause the obstruction of the portal vein. The portal outflow to the vena cava can be impeded by hepatic vein thrombosis or cardiac disorders that impair the pumping ability of the right heart. This causes blood to back up and increase pressure in the portal system. It is understandable here. Long-term portal hypertension causes several problems. Varices, yes, varices, distended collateral veins in the lower esophagus, stomach, and the long-term portal hypertension causes several problems. They can cause varices. The varices, this is distended of collateral veins, maybe in the lower esophagus, stomach, and rectum. Splenomegaly. Splenomegaly, this is a swelling of spleen. It is caused by increased pressure in splenic vein. This splenic vein, this is a branch of portal vein that connects the portal vein and the spleen. So if you have a portal hypertension, we have a splenomegaly. Ascites. Ascites due to pressure in the mesenteric vein. Hydrostatic pressure forces water out of these vessels and into the peritoneal cavity. Hepatic encephalopathy. Hepatic is due to presence of the toxic substances, particularly ammonia, in the blood that reaches the brain. We know that the ammonia, this is a residue of protein degradation. Normally, the liver eliminates this ammonia in ammonia. But when the cells of the liver are not working very well, ammonia will still free and go with the blood, and it is toxic to the brain. The clinical manifestation of portal hypertension, gastrointestinal bleeding, can be vomiting, blood from various rupturing, of course. Now, for those long term, yeah, we have gastrointestinal bleeding for the varices. Maybe there will be the rupture of the varices. Anemia due to slow chronic bleeding from varices also. Merena, the presence of digested blood in the stool. Ascite. The ascite, we understand. The ascite, this accumulation of the fluids in the peritoneal cavity. The standard collateral vein, peripheral edema, will occur, splenomegaly, hemorrhoids, and the individual usually has a history of jaundice, hepatitis, or alcoholism. Diagnosis: clinic, endoscopy, evaluation of portal venous pressure. Management: the management we can have a beta blockers, drugs. Emergency management of bleeding varices is surgical one, vasopressor. Compression of the varices with a inflatable sanks taken. This is the basic care. Sclerotherapy also. Varicose ligation. The ligation now is to close or to suture. Liver transplant in the case of early-stage liver failure. Ascite now. The term ascite refers to accumulation of fluid in the peritoneal cavity. Causes liver disease can cause the ascite. Cancer, like peritoneal cancer, pancreatic cancer, colon cancer, stomach cancer, will obstruct the normal flow and increase the pressure in the vessels. When the pressure is increased in the vessels, I've said that the water will shift from intravascular to extravascular and see where to accumulate. the space you have, enough space you have is the peritoneal cavity. Congestive heart failure also, especially this is right-sided heart failure. We have seen in the heart disorders that the right-sided heart failure cause the backup of the blood to the system in the veins. Now, when in the vein we increase the pressure, and the water will shift from the intravascular to extravascular. Renal failure also can cause it, ascites, infection, bacterial peritonitis cause also the capillary permeability with loss of parenchyma and ascites. Okay, it's okay, understandable. Mechanism of ascites caused by cirrhosis. The cirrhosis causes hepatocyte failure and or portal hypertension. You have seen it. The hepatocyte failure is responsible for decreased albumin synthesis, resulting in diminution of capillary oncotic pressure with the decreased effective plasma volume. What does it mean? Normally, the hepatocyte synthesizes albumin. The albumin, this is a protein that plays a great role in keeping water in the blood. This albumin determines oncotic pressure. This is the pressure that determines the proteins in the blood, and its role is to maintain the water in the blood. When this oncotic pressure is reduced, the blood will shift from the water will shift from the blood to extravascular. Now, when you have the failure of the cells to synthesize the albumin, there is a reduction in albumin and reduction in oncotic pressure. So the water will shift from intravascular to extravascular. That will reduce the plasma volume. The reduction of effective plasma volume will cause also increase the renin aldosterone. You have seen in renin aldosterone angiotensinogen. We have seen it. So we have seen that when the volume of blood volume reduced, on the kidney will be stimulated, will sensitize that the reduction of the volume and release the renin. And the renin will be combined with the angiotensinogen in the liver and form angiotensin 1. Angiotensin 1, when they are alive in the lungs, they will be converted by the angiotensin converting enzyme, and that will convert the angiotensin 1 into angiotensin 2. And angiotensin 2 itself can work on vasoconstriction, and or angiotensin 2 can stimulate aldosterone production. And aldosterone production will increase water reabsorption. Okay, this mechanism and antidiuretic hormone resulting in the increase of renal absorption of sodium and water. Okay, yes, we result in the renal absorption of sodium and water. Yes. The portal hypertension causes increased capillary infiltration pressure resulting in ascites. You can see when the absorption of the sodium and the water is increased, we will also have those ascites. Yeah, because those water will go to in the peritoneal cavity. Clinical manifestations: abdominal distension, dilated upper abdominal vein, inverted umbilicus, weight gain, increased abdominal gait, dyspnea also. Dyspnea, this is level of fluid, displace the diaphragm and cause this dyspnea by decreasing lung capacity. It's understandable. You can see within the cancer is having ascites, is having difficulty breathing, dyspnea. When you're having dyspnea, the dyspnea will be caused by the displacement of the diaphragm. You see, accumulation of the fluid in the peritoneal cavity displaces the diaphragm, so the diaphragm will not contract very well to increase the thoracic volume and cause dyspnea by decreasing lung capacity. So we have increased respiratory rate for compensation. You can see during the ascites, this is collateral veins on the abdomen. It is distended. Diagnosis: we can have paracentesis to aspirate ascitic fluid for. We say paracentesis. This is the drainage of the peritoneal fluid now, ascite fluid from the abdomen now. They can do paracentesis for bacterial culture, blood cell count, biochemical analysis, macroscopic examination, cytologic examination also. Treatment: treat the underlying cause. In the case of small amount of ascite, dietary sodium restriction. We will tell the people to restrict the sodium. In the case of moderate amount of ascite, give diuretics. The diuretics for elimination. You will see the diuretics in the pharmacology. In the case of large volume of fluid, perform the large volume paracentesis. The nursing management: administer medications like diuretics, albumin, IV line. Assist the physician with paracentesis. Measure the ascitic fluid removed during paracentesis. Monitor blood pressure every 15 minutes with the current on paracentesis. Monitor other vital signs like respiration to assess the severity of ascite. Measure and record abdominal girth and body weight diary. Educate the client the measures to reduce edema. Educate the client in the family the nature of the disease, cause, treatment. Provide the comfort care. Cholerythiasis. This is the presence of gallstone in the gallbladder. This is a gallstone that are formed because of abnormal bile constitute. They are divided into cholesterol gallstone 80% and pigment stone calcium 20%. This is stones that formed in the gallbladder. The cholesterol gallstone are due to the increasing in the biliary secretion of cholesterol, usually associated with obesity, high caloric and cholesterol-rich diet or drugs. And normally, when we eat the fat and even a high glucose, excessive glucose and fat, they transform into triglyceride and go to the adipose tissue. For that, every time the triglyceride release cholesterol to the river, we have seen that the cholesterol is helpful in synthesizing the bile, in conjugating the bilirubin. But when the cholesterol becomes very high, it will participate. It will participate and cause the stones in the gallbladder. So this is that we call cholerythiasis. Predisposing factor, arrhythmic factor, obesity. Because obesity has many fats, the cholesterol released so many. A female sex hormone or contraceptive containing estrogen leading to decreased bile salt secretion and decreased conversion of cholesterol to cholesterol ester. Increasing age due to decreased secretion of bile salt. Gallbladder hypomotility leading to stasis. Yes, you understand. When this is stasis now, the cholesterol and they can participate. Clofibrate therapy, increasing biliary secretion of cholesterol, decrease the bile acid secretion, and high fat diet and high calorie diet. Why high calorie diet? The capacity of the body to store the glucose is limited. So excessive glucose, they transformed into triglyceride, to the fat. Okay, that is why for those people who take high diet of calories, they are also exposed to gallbladder. to cholesterol gallstone. Pigment gallstone, genetic factors, chronic hemolysis, alcoholic cirrhosis, pernicious anemia, cystic fibrosis, chronic biliary tract infection, increasing age, ileal disease, aero resection, or bypass. What are the clinical manifestations of cholestasis? Now, the symptoms are due to biliary obstruction. Biliary colic. Now we have the severe and long-lasting pain in the right upper quadrant of the abdomen, radiated to the intercuspidor area, right scapular or shoulder. So the biliary colic now constant. This is severe and long-lasting pain in the right upper quadrant of the abdomen. This is radiated to the interscapular area, right scapular or shoulder. Biliary colic may last for 30 minutes to 5 hours. It is so long pain. If you will see the client with that so long pain, it is very severe in the right upper quadrant. Now, can last 30 minutes to 5 hours and may be precipitated by eating a fatty meal. The client may explain that when he eat the fatty meal, now the pain aggravated. Consumption of large meal following a period of fasting. The pain is frequently nocturnal. Nausea, vomiting usually accompany the episode of pain. Fever or chills reveals complications such as cholecystitis, pancreatitis, and cholangitis. Inflammation of the gallbladder was usually follows obstruction of the cyst duct by a stone. It may be acute or chronic, meaning cholecystitis. Now, the etiology factor: mechanical inflammation, chemical inflammation, bacterial inflammation. Cholecystitis. This is inflammation of the gallbladder. This is usually flows obstruction of the cystic duct by a stone. It may be acute or chronic. What is the etiology factor of cholecystitis? Inflammation of the gallbladder. Mechanical inflammation produced by increased intraluminal pressure and distension with resulting ischemia of the gallbladder mucosa and wall. Chemical inflammation caused by the release of rizorectin due to the action of phospholipase on lecithin in the bile and other local tissue factors. And bacterial inflammation, which may play a role in 50 to 80% of patients with acute cholecystitis. Now, take in mind that the cholecystitis is inflammation of the gallbladder. Clinical manifestation of cholecystitis. Acute cholecystitis often begins as an attack of biliary pain that progressively worsens. The pain may be generalized in upper abdomen as the episode progresses. The pain may radiate to the interscapular area, right scapula or shoulder. Anorexia, vomiting, jaundice may be present, low-grade fever, chills or rigor, a tenderness of the right upper quadrant of the abdomen, and enlarged tense gallbladder is palpable in 25 to 50% of patients. Malnutrition signs can also happen. This is deep inspiration or cough during subcostal palpation of the right upper quadrant usually produce increased pain and inspiratory arrest. Now, means malnutrition signs. This is it is characterized by when the client do the deep inspiration or cough during subcostal palpation of the right upper quadrant usually produce increased pain and inspiratory arrest. Now, so you take your hands, you palpate to the right upper quadrant, so and you tell the client to to do the deep inspiration or cough. And when you palpate at the upper quadra, when the client is inspired with doing the deep inspiration or coughing, now he will feel the pain. Localize the rebound tenderness in the upper. When you say rebound tenderness, now we palpate. While you are palpating, the client don't feel pain, but when you remove your hands, the client will feel pain. This is rebound tenderness pain in the right upper quadra. A diagnosis clinic now. The triad of sudden onset of right upper quadra tenderness, fever, and leukostosis. Yeah, we'll see the tenderness. This is the pain now, the pain and the swelling of right upper quadra, and we're having fever and the leukostosis. The leukostosis, this is a high number of white blood cells. The serum bilirubin is mildly elevated. Ultrasound show the correctly thickening of the or dilation of the bile duct. Bile scan can be used. Treatment: non-steroidal anti-inflammatory drug for analgesia, antibiotics such as ampicillin, ciprofloxacin, or ceftriaxone, anaerobic coverage metronidazole, surgery in case of medical therapy failure, or in case of complications, cholecystectomy is done. Let's see the disorders of pancreas. We are going to see acute pancreatitis. The acute pancreatitis, also called acute hemorrhagic pancreatitis, is an inflammatory process of the pancreas. The inflammation is due to premature activation of pancreatic enzymes that destroy ductal tissue and pancreatic cells by autodigestion, resulting in fibrosis of the pancreas. Yeah, when there is premature activation of the pancreatic enzymes that will destroy ductal tissue. Yeah, this is the cause of most of acute pancreatitis. Now, when there is the destruction of the ductal tissues, now we result in fibrosis. So there will be inflammation. When there's inflammation, now those tissues will be auto-digested, and the result in fibrosis of the pancreas. The causes can be gallstones, including mucolithiasis, alcohol also, hypertriglyceridemia, trauma, postoperative, drugs, and the cystic fibrosis, cancer of the pancreas, autoimmune, it is rare. Infections such as mumps can cause pancreatitis. The manifestation with abdominal pain in epigastric or mid-abdominal pain in periumbilical. Pain may vary from a mild and tolerable discomfort to severe, constant, and incapacitating distress. It often radiates to the back, chest, flank, and lower abdomen. It is frequently more intense when the patient is in the spinal position, and the patient often obtains relief by sitting with the trunk flexed and the knees draw up. Nausea, vomiting, and abdominal distension, chemical peritonitis, low-grade fever, tachycardia, hypertension. Shock may be due to hypovolemia, secondary to increased formation and release of kidney peptides, which cause vasodilation and increased vascular permeability. The jaundice may be present. Edema and the head of the pancreas compress the common bile duct. Enlarged pancreas with organized necrosis or pseudocysts may be palpable in the upper abdomen. A faint blue discoloration around the umbilic, what we call current sign. Around the umbilic we have a faint blue due to hemoperitoneum. A blue-red, purple, or green-brown discoloration of the flank. It is called Tanzi sign. Reflect tissue catabolism of hemoglobin. The later two findings, which are uncommon, indicate the presence of severe necrotizing pancreatitis. So those TANS signs, the TANS signs and the kind signs that will show the severe necrotizing pancreatitis. To diagnose it, we should see elevated serum amylase, elevated serum lipase, leukocytosis, hyperglycemia, hemoconcentration. We can use CT scan to visualize it. We can diagnose differentially perforated viscous, acute cholecystitis, acute intestinal obstruction, renal colic. Those are some diagnoses that can be confused the diagnosis of pancreatitis. For chronic pancreatitis, this is a disease progress characterized by irreversible damage to the pancreas, histologic abnormalities including chronic inflammation, fibrosis, and progressive destruction of both exocrine and eventually endocrine tissue are present. Cause chronic alcohol abuse. You can see the alcohol is having a problem in medical hereditary cause. Clinical manifestation: abdominal pain. Eating may exacerbate the pain. Maldigestion with steatorrhea, diarrhea, weight loss, and fatigue. The treatment is administration of pancreatic enzymes, and the treat of pain. Narcotic such as morphine and surgery can